I'm fine. How are you?
Are you on shift today?
Yeah, I'm on shift today.
Nice. How is it? Busy?
It's not busy as the usual, but it's
I'm
morning right
glad.
now, so everything's
Yeah,
okay.
it'll always go up, up, up.
All right.
I had such a busy shift today. I worked the morning to the afternoon, and it was so busy.
Really? So you choose now the topic because of night shift something? It's just that
I
my wife told me
yeah.
that.
No. This is kind of a big prestigious thing for me. My hope is that it'll allow me to come back to the University of Utah in a couple of years and help bring in more funding
Mm-hmm.
opportunities for things like this.
Mm-hmm.
So, yeah, and
All right.
I also think, Di, I think it's really important for my kids to be exposed to other cultures, and so I
All
want
right.
want that for them. But I'm sad.
Mm-hmm. Me too.
Yeah, yeah. You promised to come visit me in Africa.
I will, buddy. When
All
you want,
right.
yeah, it's very easy to go come with see you. Very easy
Yeah,
though.
I hope I'm in Asia. I hope I'm in Asia, but you can come wherever and stay with me.
All right.
Norway, Norway.
So after 2 years, you will back to Select City or something.
I think
Nice.
so.
Yeah,
Yeah.
better than
Okay.
that. So when you back Utah, you back to university again.
Yep.
Again.
They've told me they will hold my job.
Oh, really? That's nice.
Hmm.
Just
Yeah.
travel,
Well,
buddy. I
we'll
love that.
see. Yeah. So we'll see. We'll see. I can't predict the future, but
Uh,
Utah is home. You know.
I love Utah too. It's a nice
I
place
know
to go.
it's your home.
Right,
Hmm.
I know that.
Yeah.
Okay.
My home is your home. So Jane will work in my place here, and she will take over for the sessions, and I think it will be okay. So,
Mm-hmm.
and my
You know
my
that.
hope is that yeah,
What would you, brother? You are so convenient. You can thoughtful. We are brother. We are like the man. So we don't
I
we
know,
don't something like small one. Just
I know,
let's go. Everything will be okay.
I
So
agree.
works so easy and no
Yes,
no more paper for something like working
I
paper something like that.
I
So
I agree. I
girls
agree.
is so complicated. I think so.
So complicated.
Like,
Yes.
asking for something like A B C D E or something like that, but what does that? Okay, do it,
uh,
do it. Don't
you're
worry about.
you're right.
Uh,
You're right, Di. Girls are complicated, and this is why hopefully you and Ryan will be strong and not cause keep the problems from Shakira and
yeah.
and the others.
All
So
right.
my hope is I don't know until I start the job, but my hope is that I will be able to continue to come to these sessions and maybe even come visit Vietnam still. So, but
Just come.
I
Easy. It's very easy to travel around Asia.
yeah,
It's very,
I agree. It's very easy and fast. So my hope is, maybe I will be in the Philippines, maybe I will be in Thailand, maybe even Vietnam if they open an embassy that needs a physician.
then.
That would make me happy.
All right. Philippines is so dangerous. You know that.
Yeah, in some places in the south, right?
No, in Manila too.
In Manila, you think?
We
What?
we talk we read a lot of news there, but because we don't live there, so few of Vietnamese travel to Philippines. I don't know why, but maybe, but we heard a lot of something like gunshot, something like that, and the president is not friendly, something like that. Uh,
Yeah,
they travel to Philippines to go to the Iceland. There, Palawan,
yeah,
something that's very beautiful in there, but Manila is so
hmm
dangerous that we
yeah.
heard, and fewer Vietnamese come there. I don't know why, but travel
Is this
prefer.
because of Duterte before Duterte was president? When Duterte was president?
Yeah, Durate. So this is the gunman. They're not president though.
I know. Yeah, he's not anymore. Now it's, who is it? I've forgotten the name. It
Right.
is
Older
yes,
one.
Marcos now.
Marcus. Marcus. It's
Hmm.
just like Espanol. It's
Yeah,
just like
it is.
you
Yo
can
hablo
speak
español.
there.
Uh-huh.
I think like
Uh-huh. But I don't speak Tagalog, which I think is what the Filipinos sometimes speak too, right?
no English. It's just strange. And then
Yeah,
they talk, and but maybe you can understand that, right? Okay.
exactly.
So wait. Okay. It's 2 more minutes. We are
Yeah,
so early,
we've
right?
got some time. We're early. We got a chance to chat, so
Okay.
it's nice. Yeah. What is new
All
with
right.
you?
So
Imna, what are you? What is new?
what?
What is new with you?
We okay.
Yeah,
Hmm.
yeah.
Uh,
Just
uh,
okay.
yeah. We want to travel a lot, but we don't have time for that.
Yeah. So busy.
We are so busy. So if
Yeah.
we had time, we travel.
Yeah.
We went to
Yeah.
China
You're going to China?
for vacation. Something it's not
Where?
expensive. Maybe in Beijing or something. I've never been in
Beijing.
Beijing. Go
Yeah.
to the bridge. Uh, my dream go to the river.
Yeah. The Red River. Be careful.
No, the bridge, the world, the
Oh,
very big one,
or the
the
Forbidden
bridge.
City.
Mm-hmm. It's
Cool.
very near Beijing.
I'd like to visit.
Hey,
I
you know that China is very clean, and
Yeah, I know.
they good one. They those people who travel in Vietnam or United States is the old poor one, the rich one. This and that. Most of the
I
time are rich
Yeah,
and street is very clean.
the food is
And
good.
no, they're not sitting there.
No, food. The food is
Ah,
good.
the food good. They eat a lot. China eat a
Yeah.
lot. Go to the
Yeah.
restaurant, they more than 10 dish uh, a meal.
Yeah.
So
It's affordable, not expensive.
not expensive though.
Mhm.
It's
Their
just like
economy, their economy is not very good right now.
they told me that, but I think that China is better than Vietnam. It's some place because
Really?
they so fast.
Mm.
Have a lot of highway, rail, and
Yeah.
everything. So travel from city to city is very easy.
I heard Vietnam's economy is really good right now. Very good.
Mhm.
Yeah.
I think so, but it's okay when you are doctor something like you have
Yeah.
you earn 1,000 or 3,000 a month. It's okay. You can work with that.
Yeah.
You can
You can
travel
live
around.
nicely.
Mhm.
Hey, listen, did you get an invitation to lecture at VSAM?
Not yet.
What is going on?
I don't know
I'm
why. I don't
s-
know.
I'm so sorry. They're so disorganized. So frustrating.
Hmm. We are too. If you
Yeah,
get station early, you can schedule your time
right.
or vacation for walking or something like that, and you
Hmm.
can ask asking for sponsor or something like that.
Right,
But it's
right.
right now July when you have September, so two more months.
Yeah.
It's
I
so
well, I'm sorry, Dai. I wish they were more organized. I think the people at Bach Mai are not very organized, and not responding very quickly.
right.
So yeah, I'm sorry.
Oh, don't worry.
Yeah.
If they
This
don't do,
this
we
is
have an EM
uh,
diploma here. It's
I
very
know
good.
we're strong. We're
Ah,
strong.
it's strong. Thảo,
Look at
hello
this
em.
is Dr. Tao.
Dr. Thảo, yeah, have lunch, Dr. Thảo.
Yeah. Xin chào
Right.
Tao.
Hi, Mark.
How are you?
I think it is fine today.
Good. Have
How
you
about you
have you made
today?
I'm very good, thank you. I'm happy to see you, or hear you at least.
Because
Have you
I
have
breakfast
you
now.
have you made tacos at home yet, Sao? Have you cooked tacos?
It's very difficult to find some ingredient here.
No, you could make. I know you
No,
could.
I
Yeah,
can't to
I
make
have faith.
fast.
I have faith in you.
Yeah.
Yeah. I'm glad. How are you? What is new?
In the morning I have a breakfast now.
Uh-huh.
Yeah. Yeah.
Good.
Theo anh
I'm
tính
happy.
chị hay là
Yeah.
tính chị quay các năm nào
What did you say?
mà ơi các năm thì nói vậy mà còn
Oh,
sorry because I in my department so some of
that's
my
okay.
staff is talking. It's okay with you?
That's okay. Of course.
We don't eat taco here. Taco is very familiar. Bánh xèo. I think so.
Pan Xiao. I like Pan Xiao. Pan
Hey,
Xiao. Yeah, you took me.
right. Hi,
Yeah.
Ryan.
Oh, what is what?
Hi,
Ryan Ernst?
boy.
Uh,
Oh, young, always young, young boy, lovely boy. Oh my goodness, I'm jealous with your age.
uh,
I never get old, Dai. How are you? Dai, you're looking good. Speaking of never getting old.
I'm always good.
Yeah, you're looking great.
But now I always up. Don't worry about me. I'm so strong enough to be.
so ridiculous.
Good
So
I told you
funny.
my colleague that if you see many days a day when you're leaving, you are so good. You're happy that you're leaving. You're not dead. Oh, so sad. You are leaving. I think
Don't
you
be so sad.
wrong.
That is funny.
Yeah,
It's funny. It's true. When you work in ED, you meet a lot of people have sick and they die every day. So if you are so strong, you have no, disease, you have no thing, and
yeah.
you have your, situation. Be happy.
It makes you
Somebody.
thankful for what you have.
Amen.
Okay, Ryan, where are you now?
So I'm back in California right now. I'm in Fresno. It's very, very hot. But I just got done with a shift. It was an interesting shift. Had a cardiac arrest that we got ROSC with a woman that when we ultrasounded her, she kept like recoding. She had a big RV and a flat septum, so I gave her TPA, and it looked like once we scanned her that she had like some peripheral PEs, so maybe we had like busted out the main clot. I don't know if she'll survive, but it's a very interesting case. And
You sent it all to her brain, huh?
yeah, we just sent it straight to the brain. And had another guy that I don't know what it was, a young guy, 32, completely like unresponsive, found down at home, maybe drugs, but he had gotten 2 of Narcan, and then we gave him 4, and then we gave him 8. At 8, he kind of like he vomited and kind of opened his eyes, but he just was like this really weird gaze. He never really came to. His CT scan was okay. His labs were not that bad. We were setting him up. So, I mean, we tubed him because he was like not protecting his airway. And so we were setting up to LP when I left. Not exactly sure what his malfunction was.
You were poisoning.
What's that?
This is why I poisoned him.
Yeah. So then we had a whole bunch of interesting cases. It was funny. We had like 4 MVPs that all came in at the same time, and I made fun of the residents for ordering too many CTs, but then they all had like one had a sternal fracture, one had a hemopneumo, one had like T11 fracture, one had T1 fracture, one had a shattered shoulder, and so I had to kind of go back on yelling at them for ordering too many tests because they all needed all of those tests. So,
We do too, always. But insurance okay with us.
yeah.
Insurance.
Okay, Matt, let's go.
Let's go, Di. You ready? There are all these new people here that I don't recognize. Who are all these new people on here? Who do we have here? Do you see? You don't know, Di, huh? You don't know, huh? Okay. Well, hey.
Morning.
Hey, Yen. How are you?
I'm good. I'm in
Good.
I'm in a break. Well, long time no see you guys. More than
I know.
the year already.
Good to
I
see
know. It's nice to see you. Thanks for joining us.
Yeah.
Is that a picture of your actual apartment, Yen,
No,
or is this
it's
just
a virtual.
you.
nice? Very nice. Very nice. Well, we're gonna talk about it. You know, we are in the environmental module, everyone, and we're gonna talk about a topic today that doesn't have a ton of utility in Vietnam, but nonetheless is still important to talk about because it's something that is mentioned in kind of the standardized curriculum that we started, and every other diploma student has gone through it. Before I get into that, I want to talk a little bit about what Dr. Ryan, Dr. Shakira, and I have been doing over the past week, along with Dr. Dai. And what we're trying to do is restructure the curriculum to offer you a better educational opportunity. So it may be in the near future that this is not a part of our education, but today, bear with me, we're going to talk a little bit about acute mountain sickness. And Dr. Dai has assured me in the past that he has seen acute mountain sickness in patients in Vietnam. Is that right, Dai?
Yeah.
Okay. Not in Ho Chi Minh City. Where have you seen it, Dai?
Oh, sorry. I'm in my ship right now, so.
Oh, that's okay. Okay, so here is a quick case study. So we have a kind of a middle-aged male. Let's call him Ryan Ernst, with no prior history of altitude illness, but he's at Everest Base Camp. Who knows how high Everest Base Camp is? Does anyone? Ryan, you were there, weren't you, in your DIM session?
We went up to the Manang Valley, so we were not at Everest Base Camp.
Okay. If memory serves correct, it's about 17,000 or 18,000 feet, so about 3,000 meters. Does that seem right to you, Ryan? I think that's kind of about where Everest this base camp is.
I think so, yeah.
Yeah. And this gentleman presents to the clinic tent, which is a big tent, like you just saw. He's confused. He can't find his balance. He's nauseated so much that he's vomiting, and he's complaining of a headache. Those are his vital signs. Does anyone, Yen, do you see anything there that's concerning to you? Or Tsao? Okay, what stands out to me is the tachycardia and the hypoxia. And what is this? Well, I've already told you the answer. This is acute mountain sickness. And so acute mountain sickness is defined as a bunch of different symptoms, including headache, anorexia, which means not wanting to eat, difficulty sleeping, malaise, mostly caused by acute hypoxia due to elevation about at 2,000 to 2,500 meters. Okay. And here you can kind of see the constellation of symptoms that we have as we get higher. You can see these are a bunch of different peaks, with Everest being the tallest at just under 9,000 meters. And this can lead to two very, very severe consequences that fall under acute mountain sickness, which are high altitude cerebral edema and high altitude pulmonary edema. And we're going to talk a little bit more about both those really quickly. So almost a quarter of people who end up at this altitude suffer from acute mountain sickness if they are unacclimated. This means taking somebody from sea level and depositing them very quickly at this height. And as I mentioned, this rapid ascent places you at the highest risk of acute mountain illness and those other consequences, both high altitude cerebral edema and high altitude pulmonary edema. And we also know through the literature and study of this that people with a history of heart and lung disease seem to suffer this most frequently. But it can occur in otherwise healthy individuals. People who are young, like Dr. Dye, and very strong, can end up with high altitude pulmonary edema and high altitude cerebral edema, even if they've had exposure in the past to high altitude without resultant illness. The symptoms most typically start a few hours after arrival, or sometimes after a few nights' sleep for unknown reasons. This a piece of literature that was published a couple of years ago by two physicians actually from Utah, both Dr. Colin Grissom and Scott McIntosh are on staff at the University of Utah and a part of the Wilderness Medicine Society, places different patients at different risk levels. Most of us would fall in the low risk category, but as you see, those patients who have had prior history are at a much higher risk for redevelopment of symptoms, and also those patients with a very rapid ascent. And they define this as less than 7 days. People are counseled to ascend less than 500 meters per day, but that's often not practical in patients who are on vacation. So when Dr. Dye and his wife go on vacation to Nepal and only have 1 week off, Dr. Dye is not going to take 7 days to get to 2,500 meters. He is going to rapidly ascend, most likely, because he wants to enjoy his time in the mountains, not looking at the mountains from the plains. So a big question when I was putting together this lecture was, does this happen in Vietnam? And even though Dr. Dye said yes, I tend to not believe things that Dr. Dye says. First, I wanted to show you kind of a heat map of Utah. As you can see, the state that I'm in currently has a lot of mountains. We've got a lot of height above 3,000 meters. So we tend to be a very mountainous state. And we see this with a fair amount of regularity in our emergency department. Most typically in the winter, when patients come to Utah to ski, we see patients who come from New York or San Francisco or Los Angeles, where Dr. Ryan lives. And these patients who come from sea level and then rapidly find themselves at a high altitude present to our emergency department, sometimes with very severe symptoms. Well, what about Vietnam? So even though Dr. Ernst doesn't think this happens in Vietnam, you can see that there are some altitudes both in the Central Highlands and in the north of Vietnam that do have altitudes above 2,500 feet, especially in the border regions towards China. You can see that this happens. So Dr. Dye has told me that he's seen it in patients in Dalat and in Sapa in the past. Is that right, Dye? He must be busy. So let's talk about those severe consequences of acute mountain sickness, the first being high altitude cerebral edema. And this is defined by an altered mentation along with ataxia and gait disturbance and confusion. This is the least common of all acute mountain illness. And we really don't know how it occurs, but it's surmised that it's related to the hypoxic exposure that patients have at increasing altitudes with the decreased partial pressure of oxygen. We know it leads to cerebral edema and multiple microhemorrhages, and it's rapidly progressive, which is quite scary. So patients can go to bed at night seemingly normal and never wake up. There are case reports of patients arriving at Everest Base Camp with a normal mentation and their tent partners not being able to rouse them in the morning because they've herniated. This is what a CT looks like. Of course, they don't have a CT scanner at Everest Base Camp. Yeah. Did someone have a question? And you can see both the edema here, which is quite obvious because the ventrals are squished, but also the micropunctate hemorrhages that the arrows show here. And this is what an MRI looks like with these patients as well. In both cases, these were patients who were medevaced out of Everest Base Camp. They were tourists. And in both cases, these patients expired or died. What about high altitude pulmonary edema? Sometimes we call this HAPE. You may hear people describing this as HAPE. This is a non-cardiogenic pulmonary edema that's again caused by pulmonary vasoconstriction, increased pulmonary capillary pressure, pulmonary hypertension, and kind of almost a transudative process through the endothelium due to increased permeability. And it looks like this on chest X-ray or chest CT. It's the most lethal of all acute mountain illnesses, with a mortality approaching 50% in patients who suffer this. And again, can occur in really physically fit patients who spend a lot of time training for their climbing trip, even can suffer this. But again, patients with either very rapid ascent or high sodium intake or really heavy exertion or even recent viral illness seems to maybe be a patient who may suffer this more frequently. These patients present with a really dry cough. They have a low resting SpO2, and at later stages of the disease process have that kind of classic pulmonary edema look where patients have this pink frothy sputum that we all know. Well, how do we prevent this? Okay. Well, I think the first thing I want to take home is that patients need to know that this can occur. And my guess is in Vietnam, the majority of your patients aren't aware of the fact that rapid ascent to high altitude can cause these really grave illnesses. Okay. Again, tell people about this. Okay. And as a practitioner, if you seem to practice in these environments, you need to be very aware. So I don't know if this is part of your medical training, but again, it's an important topic to cover so you have it in the back of your head. Second is pace of ascent. As the Wilderness Medicine Society suggests, patients should not ascend more than 500 meters per day if possible. If that's not possible because of timing or patients don't have enough vacation time, patients do have the option for certain medications. For high-altitude cerebral edema prevention, we recommend acetazolamide, 125 milligrams twice a day, or a steroid if you have it. And for high-altitude pulmonary edema, nifedipine, 30 milligrams twice a day. Okay. What about patients who present to a center of care with suspected pulmonary edema or suspected cerebral edema? Okay. Medications are the mainstay. Acetazolamide, doubling the dose, and Dex until the patient improves, or nifedipine, same dose. Treating them with oxygen, which seems obvious. Okay, here's a guy on the Machu Picchu trail in Peru that I've seen before, who was hypoxic and probably had very mild high-altitude pulmonary edema and was awaiting evacuation. This is something called a Gamow bag that patients have available to them for emergencies at these high-altitude clinics. And what happens is this person on the left has a little foot pump that causes pressure to increase in the bag and simulates a lower altitude for these patients. So this is something that in certain instances may help. But both these measures really are just temporizing. And the most important thing is descent, getting these patients down as fast as possible, either via helicopter or by walking them out, some sort of evacuation. Descent, again, according to this Wilderness Medicine Society, remains the single best treatment for high-altitude cerebral edema and high-altitude pulmonary edema. So this is kind of a quick topic, but again, this is an often under-recognized illness constellation, and it's really important to educate both providers and patients who may be exposed to this. High-altitude cerebral edema can be very rapidly progressive, so a patient can go to bed normal and not wake up because they've died and herniated. High-altitude pulmonary edema has a very high mortality rate if left untreated. Okay. Descent, oxygen, and medications are seemingly the most important step here. So that's all I've got for y'all today. Okay. Does anyone have any questions about this? My guess is that you haven't seen this very often, if at all. But I'd love to hear from anybody, Di or Ryan, if you've seen this and or treated this before. If you could share.
I'm just wondering that, Fansipan, which is the highest mountain of Vietnam. I just have a check that it is about more than 3,000 meters.
Wow.
Yeah, and we have many trips visited to that mountain. I haven't taken it, but my friend has participated before. But they climb to the mountains maybe just a day, but maybe is it like the acute mountain sickness? Is it
Right.
from yeah from
This is the mountain.
because I have a group of my friends that they didn't have any specific symptoms. They feel still okay when
They felt okay. Good.
to the top of the mountain.
My father
Yeah.
has had high altitude pulmonary edema, a very mild case. In the United States, where my family is from, is very low altitude in the center of the country, and we would fly to go ski in Colorado. And he suffered high altitude pulmonary edema and needed evacuation and oxygen. So it's something that occurs, and he's not an unhealthy person. So this happens.
Oh, because my friends are all young people, maybe.
Yeah.
Yeah, and also maybe because of they move like each day step by step. It's not straight. I think.
Right. Good. Thank you for sharing. Guy?
You been in festival yet, man?
I've never been to. No, next time I come, you and I together.
Sapa. You go to Hanoi and the night bus to Sapa, and we can climb to Fansipan, or they have a cable. Yeah, the cable.
It looks beautiful. Does it ever snow there?
They snow 1 or 2 days, but it's just like China. It's like it's not like Utah, but something.
I see snow.
Rainy snow in
Yeah.
2 or 3
nice.
days, 3 days a year, something like that.
Super cool.
Right. Been there?
You've never been there?
No, I've been there twice.
How did you feel?
Yeah.
But then when you climb, it's so dangerous. 4 days, 5 days. You hike to the mountain and the forest. It's so dangerous there. So they have a cable. So you go into the cable and 40 minutes for riding. So very long travel.
Wow.
And the pick the fancy bun.
Oh.
Next time you've been here, let's go there.
Let's go. I'd like that.
Yeah, let's go.
Yeah, all of us together. It sounds like a good excursion.
Yeah, a team mountain climb. I like it.
Ryan, tell us about your experience with DIM. Ryan did something called the Diploma in Mountain Medicine, and he was in Nepal. And I imagine he has some experiences he could share with us about medical evacuation.
Yeah, this was a 1-month course in Nepal. Part of it was in the city in Kathmandu, and part was up higher up in the Himalaya, kind of near Annapurna. People, at the clinics, the Himalayan clinics, they see altitude illness quite frequently. We were mostly like in a learning capacity and not working in the clinics. Some people weren't able to continue some of the activities because we were at such high altitude. One day when we were ice climbing, I was not sick at all, and I put a pulse oximeter on my finger, and my oxygen saturations were in the mid 70s, but we were ice climbing that same day. So that was just the effect of the altitude. I've personally gotten pretty bad altitude sickness when we were climbing in the Andes, and this was close in Peru at altitudes close to, let's see, in meters would be more like
6,000 probably.
Yeah, around 6,000, just right around 20,000 feet, so 6,000 meters or so. And one climb I had to turn back. I had gotten a bloody nose and I was coughing up blood, and I got scared that I was getting pulmonary edema, but I don't think it was pulmonary edema. I think I was just swallowing blood, but I felt pretty bad. And I think I just scared myself because we were up there alone with no guides or anything, and you're pretty remote, so there was no other climbers and no other clinics, and so I think I just scared myself. But I haven't actually seen at altitude. I haven't really encountered bad HACE or HAPE, other than just a fair amount of just like normal acute mountain sickness.
This is a short topic. I know it's not something you see often. I think it's an interesting topic because there's not a lot of research on it, and we don't quite understand the physiology of how it happens. And so it's worth talking about. But the most important takeaway for me is that you know about it and you recognize it when it's happening with patients. So if you have a patient, even at Cho Ray, who's recently returned from Fancy Pan, is that right? Did I say it right? Fancy Pants?
Fancy
Fancy Pants. My Vietnamese is poor, and my French.
Don't worry, it's okay.
Now you can ask them about that, and you can teach them if they go back and talk to them and their families. So that's all I've got for you tonight. It's a short session. If Dr. Ernst doesn't have anything, we'll see you back at the same time next week. At which point we're going to talk about electrical injuries.
Wow, it's nice. Good. Okay. Thank you, Matt.
I'll see you all then. Okay. Goodbye, handsome man.
Thanks, everybody.
Bye.
You're looking good.
Bye,
It's
Ryan.
good to see everybody.
Always, y'all.
Bye, guys.
Bye
Thank you.
bye.
Bye, Hannah. Bye, the rest of everybody.
Thank you.
Yeah.
Bye-bye.
Thank you
See
and
ya.
bye bye. See you next week.
Bye-bye. Tạm biệt.
Bye.